The image in the New England Journal this week concerns a 53-year-old. Which one is it? Well, I suppose drug-induced reactions are possible, but they generally don't look like this. This is not pyoderma gangrenosum, where we would expect large ulcerated lesions. Pyogenic granuloma are usually the sequel to some sort of an injury process. The lesion on the bottom might fit that bill, but these others don't. Sarcoidosis could cause lesions that look somewhat similar to this, but I think we have to look at the lesions in the framework of an immunosuppressed transplant patient. And we're left with malakoplakia. Malakoplakia, at least as far as I know, primarily involves the genitourinary tract, and it's associated with bacteria, chronic bacterial infection. But malakoplakia can also involve other bodily regions. So we're stuck with that. And indeed, cultures of these lesions grew Escherichia coli and Pseudomonas, and the patient had the lesions biopsied. The lesions then show characteristic pathological changes called Michaelis-Gutmann bodies, and long-term antibiotics, and this sort of problem should go away. So I know this disease from genitourinary involvement, generally in patients that are immunosuppressed, that are chronically infected, commonly with Escherichia coli, and then these peculiar lesions develop that on biopsy show PAS positive granular deposits, and these are termed Michaelis-Gutmann bodies. So if we look at these, I think that's one, and this is probably one, and this is not a PAS stain. We'd like to have a PAS stain. This is an H&E stain, but I think that these are Michaelis-Gutmann bodies. So this requires long-term treatment with fluoroquinolone antibiotics, and sometimes surgical intervention is required. Again, classically, these lesions involve the genitourinary tract. Our patient for this week is an exception. This is pyoderma gangrenosum, and these are large ulcerated areas of the body, cutaneous areas that are involved here, generally associated with ulcerative colitis, Crohn's disease, rheumatoid arthritis, and conditions of this nature, and that's a completely different problem. And we've discussed cutaneous sarcoidosis before, and it can make excrescences as shown in these photographs. Erythema Nodosum is also relatively common, and we learned several weeks ago in the New England Journal that sarcoidosis involves JAK-STAT signaling. JAK-STAT signaling as a result of cytokine receptors being activated, and this signaling pathway can be blocked with tofacitinib. And in the example that we looked at in the New England Journal several weeks ago, a patient's cutaneous sarcoidosis got much better with treatment with tofacitinib. Pyoderma gangrenosum generally, this is not really a granuloma as such. Generally, this involves some sort of local injury. I think this example here, I assume that this lesion was treated with some sort of a cream and ordinarily wouldn't look like this, but that's a different condition than what we're dealing with today. Now, the first topic in the New England Journal is bacterial endocarditis, which today we diagnose by means of the Duke criteria that rely on positive blood cultures and vegetations as determined by echocardiography. But there are also minor criteria that involve systemic symptoms and fever and joint pain and Osler's nodes and Janeway lesions and these classical things that we learned in medical school. But today the diagnosis relies overwhelmingly on positive blood cultures and echocardiography. And the first topic concerns endocarditis. And classically, according to the guidelines, once the diagnosis is established, the patients receive 6 weeks of intravenous antibiotics in the hospital. This is a problem. And for those of you that have dealt with these kinds of patients, maintaining an intravenous line in patients for 6 weeks is a major problem. So what was done in this study was the patients that had endocarditis, and we can see that there are 400 of them here, they had positive blood cultures for streptococci and Enterococcus faecalis and Staphylococcus aureus. After 10 days of intravenous treatment in the hospital, they were randomized to an oral regimen, which they could administer themselves at home, or they were maintained in the hospital and treated according to guidelines. And the primary outcome was a composite endpoint of mortality, unplanned cardiac surgical interventions to fix valves, etc., embolic events, relapse of bacteremia, all of the things that we might imagine would happen if patients aren't treated according to guidelines. So if we look at these patients, they all had a gram-positive form of endocarditis. That's not because gram-negative organisms were necessarily excluded. The patient population just worked out this way. And there are relatively few intravenous drug users. This is all left-sided cardiac endocarditis, aortic valve, mitral valve. We look at these patients, and at least they were distributed by randomization in both groups in a similar fashion. Now, if we look in the supplement, we can find out what was really done to these patients. And these are the oral regimens. The study was conducted primarily in Denmark. These are the oral regimens that these patients received if they had Staphylococcus aureus, coagulase-negative, similar oral regimens. If they had methicillin-resistant coagulase-negative staphylococci, they received linezolid and fusidic acid, or rifampicin was given commonly, and the regimens for enterococcal faecalis endocarditis. Some of these regimens are not generally used in the United States, but they are in Europe. But at any rate, these were the regimens that were applied, oral regimens, and the patients that were reliable enough to be sent home received the oral regimens, although as far as I can tell, the patients were monitored closely in terms of their adherence. And if we look at this, all-cause mortality was substantially reduced in the patients that were sent home. And if we look, there aren't enough numbers here to have statistical significance, but the trend is there. And if we look at the primary endpoint, if anything, the oral treatment did better than the patients that were kept in the hospital and treated intravenously. I think that these data inspire confidence, because if we look at the breakdown of age, gender, diabetes, renal disease, what kind of bacteria were involved, and these were all gram-positive forms of endocarditis, surgical treatment, etc., looks like the oral treatment group does better. And again, if we look at just mortality, at least the oral treatment group certainly didn't do worse. Probably they did better. And unplanned surgical catastrophes like sudden valve rupture or something of this nature that had to be treated operatively occurred to similar degrees in both groups. So I think that we can conclude that there is an argument for sending these patients home if they're reliable, and giving them an oral regimen so that you don't have to keep intravenous lines in these patients for 6 weeks. The next paper, same topic, but this time we deal with bone and joint infections, which according to guidelines should also be treated in the hospital with an intravenous regimen for 6 weeks. This study was performed mostly in the UK, and these are patients with some sort of bone and joint infections. And these are serious infections, life-threatening, formation of sequestra, sinuses, all sorts of complications can develop here. But again, half of these patients were treated with an oral regimen outside of the hospital, and the other half was admitted to the hospital and treated with an intravenous regimen. And the primary endpoint was definitive treatment failure, judged after 1 year, when all of this was ostensibly over. And we can look at a non-inferiority margin. The argument here is that the oral regimen is no worse than treating these patients in the hospital. And again, if we look at what happened to these groups, it looked like both groups got what they were supposed to. The oral group got oral antibiotics and the intravenous group got intravenous antibiotics, for the most part with very few crossovers. And if we look at the percentage of patients that got what they were supposed to have over the initial 40 days and the follow-up at 1 year, both groups got the required amount of antibiotics. And again, if we look at the supplement, here we can find out what the patients really got. And the antibiotics that the IV group got, glycopeptides, penicillins, cephalosporins, carbapenems, etc., are demonstrated here. And the oral regimens that were given, quinolones, rifampicin is popular, of course, tetracyclines, macrolides, etc., were distributed in both groups similarly. But if we look at PO versus IV, it appears that the PO group did as well as the IV group. And if we look at that in more detail in terms of the primary endpoint, it looks like oral is better, or at least it's no worse. And this necessary criteria of no worse was maintained, indicating that the oral treatment is an acceptable alternative to the intravenous treatment. And if we look at antibiotic-related problems, more common in the intravenous group than in the oral group, frailty-related problems, these are commonly older people, keeping them in the hospital, they get demented, they fall down at night, etc. They're better at home. And of course, intravenous complications, catheter complications, were much more common in the intravenous group than in the oral group. So I think a second study indicating that these complicated infections, that oral antibiotic regimens, provided that the patients are compliant and can be monitored appropriately, is an acceptable alternative. The third paper in the New England Journal involves bypass surgery, and we'd like to use arteries for bypass instead of veins when possible. And the internal mammary artery or internal thoracic artery is a favorite candidate. The one that's on the left side is a little easier to work with than the one that's on the right side. And the left internal mammary artery is commonly implanted on the LAD, left anterior descending coronary artery. And if you have a good surgeon that can also do the right side, this is also acceptable. But this involves manipulating the sternum in a more complicated way, and complications from a double internal thoracic artery bypass graft are more common than a single graft. So surgeons have asked themselves, maybe one side is enough. And that's what was tested. This is a randomized controlled trial of bilateral versus single internal thoracic artery bypass graft. And we look at these patients 10 years out. This is 10 years post-surgery. The primary outcome here is death from any cause at 10 years. And a composite of death, any cause, myocardial infarction, and stroke was a secondary outcome. Large numbers of patients, 1,500 patients in each of these two groups. Most bypass patients are male. They're mostly around 65 years of age. They are commonly a little overweight. Hypertension is common in these patients. Diabetes mellitus is also common. Cholesterol changes, etc. You're aware of all these things. At least the patients were distributed in a similar fashion. And if we look at sternal wound complications, these were more common in the group that got bilateral grafts versus single grafts, as we would expect, because this is technically more challenging. And all the other outcomes, the primary outcome and the secondary outcomes, were no different in the two groups. So if we look at this, death from any cause, So these patients are at least 10 years out, so now that they have a mean age of 75 instead of 65, so perhaps 20% of them have died from one reason or another. Actually, that's about right, about 20%. But there's no difference in the two groups. And a composite outcome of death from any cause, myocardial infarction or stroke, the single graft group did as well as the bilateral graft group, and they had less sternal problems. So I guess most of these single graft patients probably had a venous bypass graft on their right coronary artery if they needed one. At least 10 years out, there's no difference. So that this single mammary artery bypass on the LAD is probably acceptable, and it's not necessary perhaps to have to perform this bilateral operation that is beset with more complications. So, next paper. As a nephrologist, I thought this was fairly interesting. Patients on dialysis have a problem with anemia, and so they get treated with erythropoietin, and that is a major boon. It helps these patients. It also increases their iron requirements, and exactly how iron should be given to these patients is a matter of debate. And there are some problems with iron because bacteria love iron, and the idea that perhaps dialysis patients that get treated with too much parenteral iron could have more infectious complications is an issue that concerns nephrologists. Plus, if the patients just routinely get iron in a large bolus, nephrologists have to give the matter less thought. On the other hand, if they steer the iron to try to keep the iron on the low side by reacting to the specific ferritin levels, etc., after other guidelines, this is more work. And nephrologists don't like to work too hard, and it would be much easier to just give the iron in a proactive fashion. Everybody gets 400 milligrams a month, basta. That requires less cerebral activity than adjusting the iron according to ferritin levels. This amazing hypothesis was tested, and there are 2,000 dialysis patients, and they were randomized to a proactive high-dose iron group that just got 400 milligrams basta, or a low-dose iron sucrose group. They also got intravenous iron, but here the iron was adjusted according to their ferritin levels. And if you're interested in this, you can look at the details of exactly how this was done. But it's easier to give just everyone 400 milligrams of iron and not give the matter any thought than to adjust the iron, which requires a little more work. So again, if we look in the supplement, here's the proactive high-dose intravenous iron arm. Month 1, they just got 600 milligrams, and after that, month 2 to the end of the treatment, if ferritin was less than 700, they got 200 milligrams during the first session, and if it was more than 700, this was adjusted a little bit. And then the low-dose intravenous iron arm is also shown here, and there we see 5 steps to this, and this requires more measurements of transferrin and ferritin and looking at and adjusting the iron dosage to try to keep the iron dosage as low as possible. I would think that the reactive low-dose intravenous iron arm is probably clinically the way that doctors should handle this, but that's why the study was done. And if we look here, the proactive high-dose iron group got a lot more iron, about 30% more iron, than the low-dose iron group. Now, if you believe that large doses of iron could cause patients to have more infections, this might be dangerous. But that really didn't happen. And as a matter of fact, if we look at the primary and secondary endpoints, the primary and secondary endpoints again were, primary endpoint was non-fatal myocardial infarction, non-fatal stroke, hospitalization for heart failure or death, and the secondary endpoints were infection rate. If we look at these endpoints, if anything, they occurred a little less commonly in the high-dose iron group than in the low-dose iron group, to my astonishment, I admit. And that's on the basis of either intention to treat or per protocol analysis, the results were the same. And if we look at the infections, they were not more common in the high-dose iron group compared to the low-dose iron group, much to my surprise. So if we look at this primary efficacy endpoint, no different. Well, actually, P is less than 0.04. It looks like the high-dose iron group did better than the low-dose iron group. Death from any cause, not enough numbers here for statistical significance, but pattern looks the same. And if we look at the primary endpoint in terms of recurrent events, if anything, the proactive high-dose iron group did better than the low-dose iron group. And also important, these are ferritin concentrations. And if we give a lot of iron, we'd expect higher ferritin values, and that indeed occurred. But if we look at how much erythropoietin, or ESA compounds, that the patients got over time, the high-dose iron group required less erythropoietin than the low-dose iron group, which is also another plus for the iron people. So this is an Iron Man contest, if you wish, because it looks like proactive high-dose iron does better than reactive low-dose iron in all additional categories, diabetics and how long the people are on dialysis and what sort of access they had. And if we look at adverse events, actually, adverse events were no different with the two treatments. So it looks like the trial showed that in dialysis patients, a high-dose iron regimen, a simple high-dose iron regimen given in a proactive fashion, results in a significantly lower risk of death or non-fatal cardiovascular events compared to the reactive low-dose iron regimen. That is surprising. So I looked to see who sponsored this study, and it was paid for by Fresenius Medical Care that manages most of the dialysis patients in the United States. And then I happened to know the third author on this paper, Stefan Anker. He told me he was a cardiologist, so I was interested in what does he have to do with dialysis patients. So if we look at his disclosure statement, it looks like he better be a little nicer to the folks from Abbott, because they aren't providing him with any personal fees compared to these other companies. So much for that. The review in the New England Journal has to do with advances in neurosciences, and there's a lot of progress being made here, largely because President Obama gave more funding to this area of research. And this is the Frank Epstein Lecture, which is given at Beth Israel Hospital every year. I knew Dr. Epstein, and he was a wonderful clinician and a scientist. You'll recall that he died at age 90 of a brain tumor. I talked to him when he was about 89, and he was still taking night call, as opposed to me. I'm not taking night call anymore. But then, at any rate, the topic of this very interesting review is what drives food, water, and salt intake. And this involves advances in neurosciences, and we've discussed some of these recently. One of them involves the technique of optogenetics, so that we can see which nerve fibers are stimulated in terms of a genetic profile. We can see this optically, and we can see the radiation to other neurons, interaction between neurons, and there's also chemical ways of chemogenetic tools that can be used in a similar fashion. These things can be turned on with the Cree-Lox model, where certain genes can be manipulated, and wonderful progress has been made. And these techniques are reviewed in this review as shown in this particular graph. Now, there are a lot of abbreviations here, and if you're not familiar with the agouti-related peptide and its abbreviation, or alpha melanocyte stimulating hormone, there's a whole list of these things that you can look at so that you don't get confused. And the first third of the review has to do with food intake and appetite. And probably a seminal discovery was made about 20 years ago when Dr. Friedman discovered leptin. And when leptin levels are low, energy expenditure is reduced and the organism gets hungry. Now, if leptin can't be made because of a genetic defect, or if the receptor to leptin doesn't work, then the organism is fooled, thinking that fat stores are absent, and as a result, extreme hunger and obesity occurs. So this was the first breakthrough in trying to figure these things out. Another breakthrough was the discovery of pro-opiomelanocortin. These are neurons that make this material release peptides that stimulate, such as alpha melanocyte stimulating hormone, which addresses various receptors. And alpha MSH promotes weight loss, whereas the agouti-related peptide neurons release agouti-related peptide and inhibitory transmitters such as neuropeptide Y and gamma-aminobutyric acid. Now, agouti is actually refers to a fur color, and mice with a mutation in agouti or in the in the melanocyte stimulating hormone receptor 4 have a yellow fur color, and that's called agouti, and these are known as agouti mice. That's where the word comes from. Now, agouti humans have red hair. They don't have yellow fur because they don't have fur, but these are commonly red-haired individuals that are markedly obese because they have a disturbance of this signaling pathway. And all of that is outlined in paragraphs that you can see here. Then the next topic is water balance and thirst. We know that this involves trip channels, trip V4, and the subfornical organ and other pathways, the paraventricular, I forget these abbreviations here, but these neurons, where they're paraventricular hypothalamus and the lateral hypothalamus and the paraventricular thalamus is shown here, and all these pathways were tracked with these new techniques. The end result is the release of arginine vasopressin, which operates on the kidney to result in the expression of more water channels so that aquaporin 2 channels so that water is retained. What we've known for about 35 years, thanks to Ken Johnson at Iowa City, is that if angiotensin 2 is injected into the central nervous system, the animals drink immediately. So angiotensin 2 operates on the subfornical organ to stimulate drinking ordinarily. Otherwise, this mechanism is acted upon by osmolar stimuli that work over trip V4. So all of this is outlined here. Then salt balance. It seems that the organisms are set at a certain level. At least salt intake in societies across the world is about 6.3 grams of sodium a day. That's about 150 millimoles. Some pundits feel that that's far too much, but the author of this report suggests that this is the set point, and his argument is that if salt intake is less than that, the renin-angiotensin system is stimulated. Now, what we've learned about salt intake and salt appetite is that 11-beta-hydroxysteroid dehydrogenase 2, which is the enzyme that catabolizes cortisol to cortisone, is involved in this process. And you can review this on your own in the New England Journal. Now, how these things are tuned is interesting because obviously negative feedback is involved here, but negative feedback would result in a very jerky behavior pattern because this would imply that the stomach has to be full, the food has to be resorbed until the negative feedback signals are given. And instead, there are also feed-forward mechanisms. And these signals have control over whether or not we have an aversion to hunger or thirst, or the opposite of that. And these are sort of secondary stimuli, and this is discussed in detail here. It reminds me of the saying, you can lead the horse to water, but you can't make him drink, probably because of aversion signals that are complicated but are outlined here. So feed-forward regulation plays a role here, and it plays a role in terms of all these behaviors: food intake, water intake, and perhaps also salt intake, as shown here. Now, the patient in the New England Journal suffered from eating one of these things. So what's the risk in wolfing down these things? Has it to do with the amount of calories or fat that's present in these burgers or in these mega sandwiches? And what we learned from the article that I'm going to show you next is the main danger in consuming these things is the toothpick. And I'll show you how that works. The case involves an 18-year-old man who's actually a professional athlete. His sport isn't really given in the paper, but he shows up with abdominal pain and bloody stools. That's called hematochezia. And this ends up being sort of a chronic problem, and he presents to various physicians with these complaints because they don't always occur all at once. But he has postprandial nausea, he has some loose stools, then he thinks that there might have been blood in his stool, he goes to the doctor, various lab tests are done, and these things are basically pretty much normal. There's a whole list of them here, but what's concerned is that his erythrocyte sedimentation rate is higher than it should be for an athlete, and he has signs of inflammation as shown by his C-reactive protein levels. If we look at his blood film and white counts, etc., not too remarkable. He gradually gets more anemic over time, which is a concern. Multiple urinalyses were done, and his urine's always normal. And then he gets fever, and his heart rate increases to 110, whereas usual heart rate's about 45. And he gets some imaging studies, MRI, what else is there? And MRI wasn't very helpful. And some other imaging studies are done as well. And then one day he has a temperature of 38.9 degrees centigrade. He gets some acetaminophen. And that day his stools were well formed, but they contained some blood. So he goes to his team doctor and he goes to an emergency room, and finally various things are done and blood cultures are done, were drawn when he had high fever. And the physicians didn't know this at the time, but these blood cultures were positive for gram-negative rods, more than one type. And if we look at this imaging, this is a CT, and to be fair to the clinicians involved here, the radiologists at the first reading didn't pick up all the signals here. But what we see here, RCIA is his right common internal iliac artery. The right common iliac artery, what we see here is there seems to be some sort of an inflammatory mass around the right common iliac artery. And if we look at the other plane here, it certainly looks different than the one on that side. And at second viewing, the radiologist concluded there might be some gas in some of these structures that probably shouldn't be there. And that was also noted in this lateral coronal view that's shown here. And here's the right common iliac artery. And on that day, he had some more bloody stools. So that's discussed by a young surgeon here, and she considers appendicitis. Could this be appendicitis? But there really wasn't pain localized to McBurney's point. Diverticulitis in an 18-year-old would be a little uncommon. Inflammatory bowel disease, ulcerative colitis, or Crohn's disease, these are possibilities. But the clinical picture doesn't fit these things too well. Infectious colitis is possible. Colitis associated with non-steroidal inflammatory drugs, and all athletes probably swallow those. My favorite diagnosis was a Meckel's diverticulum. But the surgeon argued that Meckel's diverticulum usually presents in young childhood rather than in young adulthood. Ischemic colitis in this young man would be unlikely. Sigmoid volvuli are more common than a cecal volvulus, but that's also not very common in an 18-year-old. And so the colon cancer, we've seen some patients in the New England Journal that had colon cancer during childhood, so I guess this can't be ruled out. Inguinal hernias, the surgeon argues that this could be a foreign body, like a chicken bone or something of this nature, but most foreign bodies are passed without incident. More than 80% of them go through. So he's sent to colonoscopy. And our gastroenterologist friend looks at that and finds the health risk factor, and it's a toothpick. So this gastroenterologist, not knowing about the CT to the details that we know about it, pulls this toothpick out. And he's left with a shower of blood, and his whole colonoscope disappears in blood, so he tries to use clips and various things to try to stem this bleeding, which is arterial bleeding. This is a squirting artery that squirts when this toothpick is pulled out. So come quick, much blood, much blood. So this patient is then taken to a hybrid OR. Good idea. That means that imaging could be done at the same time, and the first people to have a crack at this are interventional radiologists, and they put catheters in here, and they put a balloon inside this right common iliac artery to stop this immediate bleeding. And that's shown in this picture here. And these are the clips that were left by our gastroenterologist friend, who was probably rather embarrassed about taking this toothpick out, although if there are no other symptoms, it's okay to take these foreign bodies out. Then the real doctors came. And the first team of surgeons fixed the hole in the colon, and apparently a primary closure was okay and a colostomy wasn't done. But then came the vascular surgeons, and they looked at this segment that I've outlined here in these two blue lines, and he had about 3 inches of 6 centimeters of dead right common iliac artery that they had to bridge, and they didn't want to use a synthetic material because the risk of infection here was high. And so what they did is they harvested the saphenous vein from the leg on the other side. But this results in potentially other problems, and perhaps a compartment syndrome could develop because until the venous collaterals have developed in a generous enough fashion to avoid compartment syndrome. So all of this is discussed in this case, and here are diagrams. And so this is where this toothpick ended up. It ended up in the ascending part of his, he almost got it out. It's in the rectum almost, and almost got rid of this toothpick, but then the toothpick penetrated here, this portion of the lower sigmoid colon, skewered his right internal iliac artery, common iliac artery, resulting in this catastrophe. The next topic in the New England Journal that interested me quite a bit concerns poly-Adp-Ribose polymerase. And we've discussed this because this particular repair enzyme, an enzyme that's involved in DNA repair, is a target in patients that have triple-negative breast cancer. And we've looked at papers indicating that by inhibiting PARP, or poly-Adp-Ribose polymerase 1, these patients have a better prognosis. Now, this enzyme is also present in neurons, and it plays a role even in long-term memory, which I think I need. And the enzyme is really involved in DNA repair, so that all repair doesn't have to be done by hybridization. Now, what I didn't know is that in patients that have problems with alpha-synuclein, these are all the patients that have Lewy body dementia or Lewy body degenerative disease. And this occurs in Alzheimer's disease, it occurs in Parkinson's disease and conditions of this nature. And we all have alpha-synuclein, which we need for various processes apparently. But in Lewy body dementias, there are aggregates of fibers of alpha-nuclein that result eventually in neuronal death. And if this happens in the substantia nigra, patients with Parkinson's disease have this problem. And in this remarkable science paper that I fished out, here's alpha-synuclein, and it makes these fibers. And if we just add poly-Adp-Ribose to these fibers, we get these aggregates of these fibers. This is fibrillization, alpha-synuclein fibrillization. And if the entire enzyme is here, these aggregates of fibers result in cell death and the development of Lewy bodies. And in this paper, the mechanisms here, PARP, poly-Adp-Ribose, and then the polymerase also results in more of these, results in fibrillization. And this fibrillization results in toxicity and neuronal death. And in these mice, what they do here is they squirt alpha-synuclein directly into the brain. And if poly-Adp-Ribose is there, these mice have a problem. And if the polymerase is there, then they have a real problem. And then they develop this fibrillization and develop a Parkinson's-like disease. But if we inhibit PARP, same drug that we give to the poor patients with breast cancer, then this process is ameliorated, raising the possibility that by inhibiting PARP, we might be able to prospectively help patients that have Parkinson's disease. Now in the Lancet, the first topic is the efficacy and safety of statin therapy in older people. We know that statins are good for you. They're wonderful for secondary prevention, but they're also helpful for primary prevention, particularly in patients that have high LDL levels. And we know the people that are at risk that have hypertension and type 2 diabetes and that insist on smoking and body mass index elevated, etc. But do statins help people that are older than 75 years? Which I think is a pretty germane question, at least for me. And if we look at this huge meta-analysis, the benefits of statins get less as the patients get to be older than 75 years. So that for primary prevention, there's not much evidence that in people my age, maybe measuring LDL is no longer relevant. And maybe these patients shouldn't be treated with statin because then they're merely subjected to the side effects instead of having benefit from the drugs. I understand that there's some prospective trials on this issue, but that's what the first review is about, meta-analysis about. The next topic, I'd never heard of this either. Now, this involves hyaluronic acid, or hyaluron. And it turns out that if your spermatozoa are treated with hyaluron, then DNA damage and aneuploidy is reduced. And the idea here is that in sperm that are used for in vitro fertilization, if we treat these sperm with hyaluronic acid, the sperm might be of better quality and result in more success by in vitro fertilization. We looked at one of these papers last week, and these are very complicated studies because there are so many variables that play a role in vitro fertilization. But that's what's done here. Half the sperm were treated with hyaluronic acid to test this hypothesis, and the other half were not. So here are the patients, large numbers, have to have large numbers of patients that are involved with this, and then how good are the sperm, and can they swim upstream, and the density gradients, and these sperms were also tested for their fitness and hyaluron sperm binding scores and things that I've never heard of before. Sounds like a great idea. Unfortunately, nothing happened, and there was no evidence that treating the sperm with hyaluronic acid leads to more success with in vitro fertilization. So the effects are not sufficient to affect live birth rates. The next topic is lactoferrin. I'd forgotten about this stuff, but it's wonderful. In English parlance, this is called whey. W-H-E-Y is lactoferrin. And this is a milk product that results in wonderful effects, antimicrobial, antiviral, serine proteases. Stuff is wonderful. You may remember the little ditty in English, Little Miss Muffet. She actually existed, incidentally. Little Miss Muffet sat on her tuffet, eating her curds and whey. Along came a spider and sat down beside her and scared Miss Muffet away. No pun intended. So one looked to see if whey or lactoferrin supplementation would help very preterm infants, if this is so wonderful. And so this is another non-pharmacological, natural way that ought to make things better. And so they treated these preterm infants in this study. Half of them got lactoferrin supplementation and the other half didn't. And they had prospective things that they looked at here: oxygen requirements, temperature instability, ileus, reduced urine output, all of these various things listed on this diagram here. But it didn't help. And so whey was a bust, and it didn't help these preterm infants. Now the review in the New England Journal concerns Sir Dennis Parsons Burkitt. He's my favorite epidemiologist. You may this young man lost one eye at age 11, but nevertheless went through medical school and became a surgeon and was active in World War II. Now, after the war was over, he decided to stay in Africa, and he's known for the discovery of Burkitt's lymphoma. What he discovered were these huge tumors that occurred in these young children, usually on one side of the face or the other. Most of these children also had malaria, and he made the pristine observation that 50 milligrams of cyclophosphamide and these tumors would go away. These were Burkitt's lymphomas. And he sent the Burkitt's lymphomas to friends in England named Epstein and Barr, and they discovered Epstein-Barr virus, which is responsible for at least this African form, probably for all Burkitt lymphomas, but at least for these African forms of Burkitt's lymphoma. But during his travels across Africa, Dr. Burkitt got very interested in colon cancer, which is very common in Britain, but hardly ever happened to his patients in Africa. They had other problems. And what he did is he measured their stool size. He had a Leica camera, and I heard one of his talks in the 1970s. And what he did is he took pictures of these stools, and he correlated the occurrence of colon cancer, and the correlation was inverse to the size of the stool. So the idea of a high fiber diet comes from Sir Dennis Burkitt. And in the UK, here's a Bristol stool chart, and you can compare your stools with these, whether or not it's normal. Dr. Burkitt would think this one is normal, not that one. But you can look at the quality of your own stools, because this review in the Lancet concerns carbohydrate quality, particularly fiber, high fiber diet. And Dr. Burkitt would be very interested in this review. And you can look at the variables that they looked here: coronary heart disease, type 2 diabetes, colon rectal cancer, change in body weight, and all of these other variables that are shown here. And as we look at all-cause mortality, coronary heart disease, colorectal cancer, type 2 diabetes mellitus, compared to total fiber intake, looks like Dennis Burkitt probably had a point. And if we ate more fiber, we might be less inclined to get these problems. And another analysis, whether you use a spline model or linear models, it looks like Sir Dennis knew what he was talking about. So you might consider that as you adjust your diet accordingly. The second review concerns Anthropocene. This refers to time epochs. And we live in the Anthropocene era. And that is when humans are on the planet, actually this diagram that you can't see here shows the world at night. And we're burning all these light bulbs here. That's the United States. We do a little better in Europe. And in China, they burn a lot of lights at night too, generating CO2. And so we look at the human beings and we look at energy expenditure and energy requirements and the use of natural resources and the wastage of water and all of these various things and CO2 production and destruction of the environment. And we might draw the conclusion that the Anthropocene era has little to recommend it and probably will end in a catastrophe. So this review involves food in the Anthropocene era. And here we have this young lady, probably in the Middle East somewhere. Looks like she's got a pretty good market. And to maintain this food intake amongst 7.5 billion people is sort of a problem. And so if we look at red meat consumption, the pink here are the North Americans, and they eat a lot of it. And Europeans are orange here, do a little better. Starchy vegetables, how many eggs, poultry, dairy, fish, vegetables, and what various populations ingest the amounts of these various things. And this is 2016 dietary intake. So the rich people are up here, and you can see where the patients are, the human beings are distributed. Then the authors try to calculate what needs to be done to avoid the Anthropocene epoch for ending up in a disaster. Non-CO2 related greenhouse gases, emissions from food production. Because if we eat all these meat products, we have to feed all these poor animals vegetables, and you're aware of the problems. And so recommendations are made here to avoid catastrophe. And we can look at what is going to happen to the moist tropical forests and to the tundra and boreal forests and to the desert and various things. So you might have a look at this if you're interested in this topic, and animal sources of food in sub-Saharan Africa, and nitrogen cycling and phosphate cycling and freshwater use. And these results do not inspire confidence that we're going to get out of this problem alive. Item number 2 here, at least the authors mentioned that, by 2050, there'll not be 7.5 billion people on the planet. Instead, there'll be 10 billion people on the planet. And the authors make no recommendations concerning this problem. They don't regard it as a problem. Politically, it's untouchable anyway. So I guess we'll have to figure out how to solve this problem. I'll leave that for the next generation. Then I'm going to close with a couple of patients that were mentioned on a German television program called Adventures in Diagnoses. And this was a week ago, and it concerned a young woman that showed up with a huge spleen and a huge liver and funny looking macrophages, and nobody knew what was wrong with her. And she, eventually they decided that they might do a bone marrow transplant on her. Then somebody looked at these macrophages and a diagnosis was made. So what we see here is these macrophages are filled with these funny little things here. These are Leishmania parasites, and this patient had systemic leishmaniasis, and then in retrospect, she'd been in Greece a couple of years ago and nobody noticed. So this condition can be treated quite nicely with liposomal amphotericin B. And it reminded me of what I learned in medical school. What are the causes of really big spleens? Malaria is up there, schistosoma mansoni is up there, chronic myelogenous leukemia is there, leishmaniasis and Gaucher's disease were the 5 things I memorized. So leishmaniasis belongs to this. Here's another case. This one's out of the Lancet. Look at this wonderful CT here. Here's the liver. It hangs down to the pelvic brim on the right side, and the spleen is even bigger. It hangs down to the pelvic brim on the left side. Another 49-year-old lady that had spent time in Greece and hadn't noticed. But somebody looked at a peripheral smear. Here's a macrophage filled with leishmaniasis. And this is spread by a sand fly. And this fly is not called phlebotomus for nothing. Phlebotomus perniciosus. And it spreads leishmaniasis. So with that thought, I'll leave you alone. Next week, I would like to do this exercise on Monday afternoon because I have to go to Singapore for several weeks, and it's going to sort of confuse my time scenario, but we'll figure that out. All the clinical journal clubs will occur on schedule, but perhaps not on the same day and on the same time. So thank you for your attention.